the Pediatric Lounge, a podcast taking you behind the door of the physician's lounge to get a deeper insight into just what docs are talking about today. From the clinically profound to the wonderfully routine and everything in between. Good morning, everybody. And today we have a wonderful guest, Dr. Seth Kaplan. And the topic of our conversation on our podcast today will be preparing for the unknown unknowns. Before I start on today's topic, I want to express my heartfelt condolences and the sadness that I feel for the loss of life to our brothers and sisters, our friends, our neighbors, our colleagues, our fellow parents in Texas, in light of the tragedy of a unpredictable storm, natural occurring that took the life of many young children. I am also deeply wounded and grieve deeply from the post of one of our colleagues practicing in Texas, where her words were absolutely devoid of kindness and in no way exemplifies the work that I have done as a physician, the colleagues that I know in pediatrics, and they do not reflect how pediatricians across America feel about our neighbors, people we disagree with, people we don't worship with, people that don't look like us. They're all human beings. And in our exam room, you are all welcome. And we love you all equally. And we only hope that our patients live long enough to bury us. And that if we cannot do that for your children, that we are a pillar when you are suffering. With our hands open, our hearts open, and our love towards you. To the people of Texas, I apologize on behalf of all pediatricians practicing in the U.S. for those horrible words. This is not a colleague. This is someone who is obviously not fit to practice. And I wish whatever God you pray to brings healing to your state. So today we're joined by Dr. Seth Kaplan, a pediatrician whose calling started early. Growing up in New York with his own health challenges, he was inspired by a pediatric team that cared for him and his family, an experience that shaped his career. For 25 years, Dr. Kaplan has practiced in the Dallas-Fort Worth area, evolving from traditional pediatric care to more holistic approach that includes extensive training in behavioral and mental health. His advocacy work is impressive and extensive. He served as the president of the Texas Pediatric Society, which is the state chapter of the P in Texas, during COVID pandemic, and appeared in media over 200 times to ensure children's voices were heard in policy decisions. In 2022, Dr. Kaplan faced his biggest challenge when he was diagnosed with lymphoma. Now cancer-free for over 2 years following successful treatment, this experience as a patient has given him insights into what families go through daily when they're patients. He has since incorporated wellness methods such as meditation, kindness into his practice, helping families manage the increasingly stressful world that we live in. Dr. Kaplan has been recognized as a warrior for children in mental health care in Texas and beyond. Dr. Kaplan brings both professional experience and personal understanding to every patient. Welcome to the Pediatric Lounge. It's a pleasure to see you.
Thanks, Harp. It's great to see you too.
Now, of course, we always ask our guests, why did you become a pediatrician?
So you already said it. I had a series of health issues when I was younger and was nothing too crazy serious now looking back in retrospect, but was amazed by the work that my pediatrician and other specialists who took care of me did. And my pediatricians became people who just mentored me from a very young age. I saw them a lot, and they opened their doors and they let me shadow them, and they took interest in just learning about who I was. And that stuck with me forever. So when I decided to take the leap and go to medical school, I went in with the mindset that I was going to become a pediatrician, kept an open mind as I went through my rotations. But ultimately, everything came back to the pediatricians were the people that I wanted to be with and learn from and really focus on those early years and focus on prevention, focus on thinking about how we can create healthy adults.
And then you have a dream career in the East Coast, Duke University. And why did you move to Texas?
Well, it's all Duke's fault, actually. I grew up in a small, I was born in New York City, but grew up in a small town up near West Point. Eventually went to college at Cornell. And then there was something in me that said, I've spent all this time in New York. I need to experience something different. So I ended up going down to Duke for med school. And that's where I met my wife. And my wife is from Texas. I had never really interacted with folks from Texas before. And she comes from a huge family that grew up in Tyler, Texas, which is a small city about an hour and a half southeast of Dallas. Most of them eventually made their way to Dallas, but some are still in Tyler. And I was just welcomed in Texas with open arms. And so when she said, I kind of want to head back to Texas, I said, okay. And not having any idea what I was getting myself into, really. And of course, I had dragged her up to Boston for a couple of years to do my pediatric training. And I said, okay, you spent 3 years in Boston in a place you probably didn't really want to live, even though we had an amazing time there. I'll give you Texas. And here we are 26 years later.
Do you drive a pickup truck?
I do not drive a pickup truck. I don't even own cowboy boots. I am forever a New Yorker. My kids are Texans, but a little bit of that Northeast is rubbed off on them. So my oldest just graduated from Cornell, and he's actually going to be teaching in Connecticut next year, and we'll see what happens.
Wow. And I just asking this question because I've never lived in Texas. I've been to Texas a couple of times, but you know how it is when you're going to meetings and half the people are not from Texas, so you don't really experience what the state is like. Are people from Texas that much different from people from New York, like politically and their kindness and their humanity that they exhibit?
So there's a lot of similarities and there's differences too. I think that you will not find a state with friendlier people who care for each other and come together than here. In some ways, just like how New York City can feel like a really kind of harsh place, but in a crisis, you wouldn't want to be anywhere other than New York City because everybody comes together to support each other. And that sense of kindness really does happen here. I think the politics have gotten a little skewed over the last 10, 15 years or so, but there is still just a sense of caring for each other and a sense of community and a sense of coming together and frankly a much easier cost of living that that has made this an easy place to raise a family surrounded by just a community that embraces you.
Well, well, it's a big place. Every time
It's
I go to Houston or Dallas, it's so big. It's just so big. It's just like the highways never end, and there's more and more subdivisions and more subdivisions. It's amazing. You've been very involved in organized medicine. Why do you think it's so important to volunteer in these organizations?
So I was involved in organized medicine from the time I was in medical school when I was introduced to the American Medical Students Association. And we were always invited if we wanted to go to the North Carolina, whatever the pediatric,
The chapter.
the state pediatric chapter. They invited us to their annual meeting. They invited us to the same for the family medicine group, and I got involved. And you could see that what we do in the exam room is a one-on-one thing, and it's super important for our patients and for our care for them and care of the community. But if we were to really want to make a difference for pediatric healthcare on a large scale, you had to get involved in organized medicine. Saw that further in training in Boston and coming to Texas. Like it took a little while to find my footing and to figure out where I fit here. But after a couple years in practice, it became clear that I had some ideas that I wanted to see if they would work in ways that sort of how general pediatrics was practiced was different in the Northeast than it was down here. And if you come down here and you just start saying, I got better ways of doing this, people are going to laugh at you. You're the outsider. So getting involved in organized medicine allows you to meet lots of people who are involved. And I've been fortunate to have so many amazing mentors down here who've done far more than I could ever imagine doing in my career, and find my place and find where you can bounce those ideas off other people. And so I got really involved with, we have a committee on administration and practice management and a committee on mental health. And those two places became my home. And I got to meet the most amazing pediatricians. And then all of a sudden you can get stuff done because you're getting connected to the folks who've been doing this work in the state for a long time. And then we spent a lot of time doing that work at the state level. And then why not get involved at the national level? We'll have the chance to impact pediatric policy and the care of children and their families for the whole country. Nothing drives me crazier than when I'm online and I see people saying, what has the AAP done for me? I'm not going to be a part of the AAP anymore. They don't, whatever.
I'm one
About
I'm
this
one of
all
the
the
ones that
time.
I'm one of the ones that drives you nuts because I
It's
just
okay. If you're not at the table, then you're on the menu for dinner. You can't complain and not. The AP is a member-driven organization, and I've had the chance to get to know now so many incredible pediatricians from across the country, spinning it back out from Texas, who are just amazing mentors and amazing role models. And I play my small little part to make a difference, but that's able to happen because there's so many of us who devote our time to all of this work.
yeah. So I think that where I would differ with you is I don't think you have to send your dues so that the hired hands can make $800,000 a year running the organization. The volunteers in the organization are what are the heart of the IP. And for the most part, although sometimes I disagree with their politically motivated messaging, their hearts are in the right place. They care about the specialty and they care about the children. So what I made peace with is I don't give money to people unless I know how the money is being spent and I think it's being spent well. That's how I see charity. And I like to do charity close to home, starting with family. That's just my personal ethos.
Yeah.
And, but where there are opportunities to work with the P to do good, I welcome those opportunities.
And
Even though I understand I'm an outsider because I don't play by the rules, but
sure.
I welcome those opportunities. And it's a different, a nuanced way of looking at it.
And I'll just add, I don't agree with everything the AAP does. And Lord knows, in Texas, people often say the folks in Chicago and New York don't understand what life is like here, not there. But I can disagree with some things that they do. But if I have a seat at the table, I can make sure that voice is heard in a way that may lead to change. And I'm still willing to do that.
Yeah, I admire you for that. Now, being the president of Texas Society, Pediatric Society can't be easy. But being the president during the middle of pandemic had to be incredibly difficult. What was that time like, and what was your biggest win that you think you did for the kids?
So that was a truly crazy time. And again, fortunately, I am surrounded here by other amazing pediatricians and a staff for our chapter that is just absolutely incredible. And having their support and having their help meant that even though it was a hard job, it was a doable job. I had no idea what I would be spending my time on. You go in and you have these goals of what you hope to accomplish. And then sometimes you're just somehow right person, right time. I'm a pretty private, quiet person. I've always shied away from kind of public appearances and stuff, but I'll do it when I'm doing stuff for the kids. But that year ended up being so much about media. And I pretty much got a crash course in how to do media well and ended up having a knack for it. And I think one of the biggest things that we accomplished was to raise the profile of how COVID was affecting children, which wasn't necessarily how it was affecting them medically. It was the impact on their mental health and well-being. It was the impact of school closures. It was, are they going to have a vaccine that protects them? Do they need a vaccine that protects them? What does that mean? And we were really able to elevate children's voices through traditional and non-traditional media in a way that made sure that the kids were not forgotten in all of this. And I was surprised, like doing all this TV and whatever. I was like, does anybody watch TV news anymore? And the the feedback I got from people all over the state was just incredible, that they were seeing these media appearances. They appreciated that we were not letting children's voices being forgotten. Traditional media lives on online through their social media and whatnot. And I really feel like that made a huge difference. And it also served to help pediatricians not feel like they were all alone in this. Because this was a time when we couldn't come together, and we created spaces online for pediatricians to come together that were successful. But we made sure that voice wasn't lost during that time.
I think
Remember, Seth, remember, I'm back. If you
Hey,
remember,
George.
how are you doing? If you remember back in the day during COVID, the big thing that the AP did through SOPM, or what the big thing that SOPM did was get everybody together and give information. The SOPM listserv was very busy. And kudos to Dr. Sue Berman, because she created that roadmap on how to apply for the PPP loans.
Right.
Basically, all you had to do was follow the steps and you probably were good.
yes,
That was amazing. And then also the AP had their weekly series or biweekly series of updates that were amazing. So like I always had, when I was doing media, the media folks at the AP would always provide information as needed. But through those weekly or biweekly COVID updates, like I always had all the information I needed at my fingertips.
I think that you've said a couple of things that are very important. And I think you probably know Leah Gina well in Michigan. And you might know Seth Toback, who's a
Yeah.
pediatrician.
Yeah.
And Seth Toback is married to she used to be a child forensic psychologist. And both Leah and Susan Toback said something to me that is very profound. Humans are still herd animals. We need to, like the cows, when it's cold, they come together and they rub against each other, and that's how they stay warm in cold weather. Humans need to be in touch with other humans.
Right.
Otherwise, we wilter. That's part of our water and sun, like a plant needs water and sun and soil. We need community. And one of the devastating impacts of COVID was the destruction of the community for children, which is their schooling. And but on the bright side, because I'm being too pessimistic today, is that the state chapters of the P did a Herculean job of maintaining the morale of the pediatric community during a most trying time where people were losing their incomes, didn't know what to do with their patients, didn't have any therapeutic. There was no therapeutics. You didn't know what to do with this virus. We didn't know the
Right.
natural history of it. And if it wasn't because of the state chapters, we would be much worse off. And all these
Right.
people like you that work so hard through such trying environments are just my heroes. And there's 50 of you.
Thanks. Well, we also, one other thing that we did was schools here did reopen a lot earlier than schools where you are. And so we spent an incredible amount of effort to make sure that schools could open safely and that schools had the support that they needed to do that.
Yeah. Now, at the national level, you wear many hats right now, right? Some I understand, some I don't understand. So you're on SOPM on the executive committee, and that's a section on practice management. One of the.
I'm not on the executive committee though.
Oh, I thought you were in the executive committee.
No.
Okay. So SOPM is the largest one of the largest sections of the AAP. Okay. And then you are the liaison to COPAM from.
Correct.
And so that's where I get confused, because to me it sounds like SOPM and COPAM overlap quite a bit, because they're both in the space of managing practices.
Little different. COPAM is the Committee on Practice and Ambulatory Medicine. And it's really about looking at all of the policy work that comes out of all the various AP committees, councils, and sections, and making sure that whatever policy comes out is applicable and implementable to general practice. And so it really has that policy-based focus. And we review everything that comes out of the academy before it gets published to make sure that when AP comes up with some new policy, that practicing pediatricians aren't like, are you kidding me? And that's really the focus of what we do. And then we're also involved in some policy writing ourselves.
So I'm going to be a little bit of a critic there.
Huh?
The AAP practice guidelines on obesity.
Okay.
They call for intensive therapy of 1 hour once a week for half a year. When you guys looked at that, I don't know if you were at the committee at that point, but when you guys looked at that, did you really think that outside of academia, anybody had the resources, I'm talking pediatricians, parents, children, to actually implement that?
I don't remember the specifics, but what I will tell you is we push back on things like that all the time. And just because we push back on it doesn't mean it ends up in the final policy as it's written.
Yeah.
It's just our opportunity to push back, and things are going to be fine-tuned as much as they can, but we don't have the ultimate sway in what gets published.
So you don't have veto power. You have an advisory role. We don't think this could be implemented.
Right. We raise concerns, and sometimes we'll raise critical concerns. I'm thinking of something we're reviewing right now that we're not allowed to talk about what we're reviewing before it's published because it's confidential and whatever. But there is a policy that we're reviewing right now that called for certain treatments that were going to be totally unrealistic and cost tremendous amounts of money. And we were like, you can't publish this if it can't reasonably happen. And now we're not sure what's going to happen with it, but those are the kinds of concerns that we raise.
This is only going to get worse, right? Because all pediatricians are vaccinologists. If you're not a vaccinologist, you're not a pediatrician.
Right.
If your middle name's not anticipatory guidance, you're not a pediatrician. We tell people what to do about everything. When to go to bed, when to poop, what to eat. But lately, the world of prevention as it relates to infectious disease is changing rapidly. So the first bomb was Beyfortus. Beyfortus is not a vaccine. It's a monoclonal antibody.
Right.
It's a therapeutic intervention. But it prevents infection with RSV. Luckily, it is moderately priced at $500 a dose. And there's a limited number of people that benefit from it, 3 million newborns. But now Gilead has come up with a similar therapeutic intervention that you take twice a year as an injection, and it prevents you from getting infected by AIDS, by the HIV virus. But it costs $14,000. And that's going to be a problem as to how you think about that. Who do you give it to? Do you give it to every 14-year-old girl? Teaching them how to use a condom is much less expensive. Or even teaching them not to have sex until they're 22 is much less expensive. Okay, it is, but someone's going to forget. You can't do it after the fact. And it's not a vaccine, so who is going to pay for that intervention? The other one is, I forgot the name of the company, but they did a phase 3 study. They've put an antiviral, the FC portion of something, and they give it to you, and then it is more effective than the influenza vaccine in preventing you from getting influenza. And all sort of questions come up. What is it going to cost? Because it is not a vaccine, we should not repeat the mistake that we did with Beyfortus of saying it's a vaccine when it's not a vaccine, because we confuse people just for the sake of being expedient and DEI. Because if we didn't have Beyfortus be a vaccine, then the health plans weren't forced to cover it, and it would not be in VFC, and the states couldn't afford the $500 spend to cover the babies, so they weren't going to get it. That it was done for the sake of being equitable and doing it, getting it done through the.
But if they didn't do that, then nobody would have gotten the Beyfortus.
Nobody would have gotten it. But two wrongs don't make a right.
So it becomes a treatment if you do it the other way.
Yeah, and they're not.
In essence, it's a shot. People see it as a shot.
It's not a vaccine. So with this new product in phase 3, who gets it? Everybody? People at really high risk? What happens to what we were taught with antibiotics and antivirals? If you use them too often for prevention, the viruses and the bacteria evolve and they become multi-resistant. And all these things are going to theoretically land on your committee for an evaluation.
So when we sift through the data and we look at the information that's been presented and we talk about it and we think about it. I certainly do not have the answers right now.
No, I know. And just saying, like, there's all these arguments about the flu vaccination right now. And I'm like, my goodness, look at what's coming down the pike. It may be that vaccinations, which save so many lives, are no longer going to be the only pillar in prevention of infectious diseases. And the next pillar is incredible, but also incredibly expensive.
You think they run into this problem with the hepatitis C?
That was a different, because that's a very narrow set, and it's a $90,000 spent, and you are cured for life. And if you're not cured, the liver transplantation costs about $1.5 million.
Wow.
So it's that $90,000 saves $1 million. And so that was it. But that's a cure. That's not prevention. That you have hepatitis C, you take the medicine. I think it's 6 weeks, a pill for 6 weeks, you no longer have it. So this
is why do all these drugs have to be so darn expensive? I don't think that expensive overseas in third world countries and so forth.
They're not. And the HIV intervention, Gilead is licensed to see 6 different not manufacturers of generics overseas. so it can be distributed in third tier economies at the lowest possible cost. But they're not going to do that for developed markets like Europe and Canada and the US because they need to make a profit somewhere. So we're subsidizing the world. And you could argue it both ways. We shouldn't have to. If we can, why not? That's just a circular argument. And now, COPAM also does a periodicity schedule, right?
So the periodicity schedule is the schedule that we all use that determines what screenings and tests and whatnot you're supposed to do at every well visit. That's actually administered as part of Bright Futures. And Bright Futures is a project of the Healthcare Resource Service Administration of the government, which works in conjunction with the P. They refreshed the Bright Futures Advisory Group last year, and we had the chance for a couple of us from COPAM to sit on the periodicity schedule part of that. And we do work on when there's requests for new things to be added, not that there's any space for anything to be added because it's already far too busy and there's far too much to do in the limited time that we have to do our well visits. So we take a look at, is there anything that can come off? What's the data behind it? And there's a big project to modernize it so it's not just sitting on the big fold out
That PDF
paper that you have to look, or the PDF.
Yeah.
And so we're working on modernizing it to make it a more interactive tool and a more concise tool that's easier to follow and understand, and that hopefully at some point will be much easier to plug and play with electronic medical records.
But there's two tracks, right? So one track is codified by law. And it's the same process as the Task Force on Preventive Services and the Advisory Council on Immunization Practices. And it does not have to be the AP. It's just the HRSA paid the AP a certain amount of money for 5 years to make the advisory group. And they advise the administrator of HRSA as to policies in preventive care for children. And then that's open to public comment.
Correct.
And then if the HRSA administrator, and this is because of the Constitution, agrees with the recommendations of the expert panel, then the payers have to provide the service without cost sharing. That's one track. And if you don't do it that way, this is all in the weeds, but that's what at the end of June, the Supreme Court said. Basically, they didn't say this in writing, but the Task Force on Preventive Medicine is not a principal officer of the government. Therefore, they don't need to go through Senate confirmation. Neither are the people at the ACIP, neither are whoever advises HRSA, because it's all the same law. The downside of that is that one of the measures there is the HHS secretary can hire and fire at will anybody in that advisory role. And that is part of what the Constitution demands. If they're not fireable at will, then they would become principal officers and they would have to go through Senate confirmation to play that role. So it's incredibly complicated. But then there's the advisory group, because you can't get things onto the table that are not sanctioned by a HRSA and not subject to that law. And so what does that advisory group do? Do they vote on things? Do they just advise? What do they do and how does it function?
We basically consider the evidence that's available using a combination of AAP policy, recommendations from the U.S. Preventive Services Task Force, try to come to a consensus based on available data. And of course, look at, is something a common enough issue that everybody should be doing it? Or is this really representing a certain niche population that doesn't need to have a recommendation for a universal screen? And so it's considering all that evidence and coming together to reach a consensus from it.
So when you say, what the task force uses is an unmet need. So what crosses that threshold? If a disease it happens 1 in 100,000, is that too infrequent to consider putting it on the schedule? Is there like a ballpark
No,
number?
I don't have the ballpark number
So we
for
don't.
that.
So it
Yeah,
varies on the disease.
I think so.
Okay,
And again, yeah,
it's very.
I'm learning a lot about this process as we go through it.
No, no. That's why I want to have the conversation, because it's very opaque and very complicated. And so evidence is a big thing. It has to be not
Yes,
not expert opinion.
we look for evidence whenever possible. And there are things on the schedule that don't necessarily have a whole lot of evidence that we may take a look at and say, should this be there?
Okay, so evidence is very important, and if it's graded, you're going to look at A and B.
Correct.
Yeah. And then how about cost?
Cost is absolutely taken into consideration.
Okay. And so cost is important, cost to society.
And cost of whether doing something that has the potential for any harm or
Okay.
side effect per se. So all that's taken into account.
And how about cost to the practice?
Yep.
Okay, because that's also important, right?
Oh yeah.
If you're
Absolutely.
gonna bundle one more screen into a well-child exam, I can't do it. I just don't have the money to do it. What do you want me
Right. We raise that point all the time.
Okay. And then do you consider the cost to the patient? Okay. So you
Yep.
consider what I call all the 3 opaque cost centers of healthcare in the US.
Yeah.
What we pay for as a society, what it costs to provide the service, and what it may or may not cost the patient to use it. And then you could potentially put it on the schedule without going through HRSA, but then the law doesn't apply. It's just a recommendation from the academy.
I believe so. I think we're so in the weeds. This is where I get confused.
I know it's very confusing. That's why I'm like, okay, all
We're
right.
just doctors, Herb, not politicians.
no, this
We
is
should see
important.
patients and make people better.
That's not true, because
They
as
are.
Dr. Kaplan said before, in the exam room, some days it's great. You can really change somebody's life
Yeah.
for the better. But to make a meaningful impact in more than one person, you need to understand these processes, and you need to work with these processes so that you have a greater impact in what you're doing for the kids. And that's basically what they're doing up in Chicago, is trying to figure out what has the best impact, the most potential to being impactful when we're taking care of kids. And that's incredibly important work. We need to do it, and we need to understand it. Maybe I'm wrong. You think I'm wrong, Seth?
No, and that work happens in other places too. That work happens in state houses. That work happens with community partners. There are a myriad of opportunities for pediatricians to be advocates, to make a difference for the care of kids in society as a whole. And it's sometimes just dipping your toes into one of those areas to see what role you can play can be very meaningful.
Yeah, I agree. And now I think you're on the board of something called CHIA.
CHAI.
CHIA. Okay.
So
What's that? What role do you play there?
Sure. So that stands for Community Homes for Adults Incorporated. And it is a Jewish-based organization here in Dallas that provides services to adults with intellectual disabilities. So they have a series of homes that adults with intellectual disability can live in semi-independently with support. They also provide support to folks who don't live in their homes with intellectual disability. And I was asked to serve on the board as someone with experience with doing some work around advocacy on Medicaid, as they really rely on Medicaid for a lot of their funding. And for me, it represents being able to do something that isn't directly pediatric related, but yet is so important to our pediatric populations. We care for so many children with intellectual disabilities, and then we send them out into the world and hope that they're going to be okay. And this is actually a chance to see that continuity come to fruition better. So I've served on many different boards of directors for Jewish communal organizations over the last 25 years. And this one in particular, it occupies a special place because, again, it gives us the chance to see where our kids with intellectual disability can thrive as adults who need support to survive as adults. And it's also opened my understanding of all the challenges that parents face and how early they need to start thinking about what life is going to be like as an adult for those kids. And has helped me compile resources to share with families at a very early age to make sure that they move in the right direction.
And you have a very personal story about change management. May I ask you to share that on air?
Yeah. And you have to pardon me. It's now almost 3 years that I've been cancer free, and yet it still makes me tear up when I think about it. We talked about the struggles that practices had during COVID. As we were emerging from COVID, all of a sudden our practice got busy. We were seeing it. RSV made a comeback, flu made a comeback. All of a sudden, like, we were just busy again. And frankly, we were in the best financial shape I could possibly be in, or so I thought. And I owned my small practice for 21 years. And there's a lot of lessons that you have to learn as the owner of a small practice, and you keep your eyes on everything. As the fall of 21 was going on, all of a sudden, something was wrong, and you just know something was wrong. And I'm a distance runner, and me and my running group decided we were going to try to run a half marathon in Dallas as our sort of comeback from COVID race in the fall of 21, because we hadn't run a race together since before COVID. And so we started training with them through the summer and the fall, and I just was having a hard time keeping up. And it didn't make sense. I was like, okay, we've been out, we're not doing much, I'm out of shape, whatever, but it was not keeping up. And I'm having a really hard time. I finally went and saw my physician. I said, something's up. And they run their battery of tests that internists do. But excuse me. And I had a case of hyperthyroidism right before COVID started. And at the time, my CRP was through the roof, and I was floridly hyperthyroid. It ended up not being an autoimmune thing. I recovered. I was fine. So my internist does all these labs, and everything's perfect. He's thinking it's my thyroid acting up again, except my CRP is really elevated. And so we need to put you on a statin. I'm like, what do you mean you need to put me on a statin? He says, if your CRP is elevated, it means you're at risk of a bad outcome from having a heart attack, but I don't have high cholesterol. I don't have a family history of early heart disease. Didn't make sense to me. So he decides to do a calcium score for the heart.
Yeah.
And it gets delayed and delayed for various reasons. And meanwhile, I'm just getting sicker and sicker. All of a sudden, I'm short of breath all the time. I can't speak. I can't walk. And this whole time, I'm just trying to take care of patients still. Finally, excuse me, it's allergies right now. Finally, January rolls around. We are just super busy. I am working nonstop, and yet I can barely get through an office visit because I just can't speak. And I get this calcium score done because I'm like, something's got to be up. And I get a call. It's Valentine's Day. And I get a call at 5:00, and the doc says, hey, I've got good news and bad news. Good news is your calcium score is 0. Your heart is great. The bad news is you have a huge mass in your chest. And so all of a sudden you're thinking, okay, we went through all these financial difficulties. I've been through financial difficulties before, but you always come out of them. And now the last thing I want to think about is, what do I have to do to keep my practice going? And I don't know what's going on. And that started a couple week period of unknown. We didn't know what it was based on I got a CT done, and radiologist who I know pulled me in the room, and he was like, Seth, I don't see how you're standing on 2 feet right now, because this mass had destroyed half of one lung, was eating into my heart, had completely encased part of my aorta and part of my carotid. And he was like, there's no way you should be even like talking to me right now. But because I'm a runner, I developed so many collaterals to help me deal with all that. I was somehow getting by. Working with the oncologist, trying to figure out what it is. I got sent to a surgeon because they thought I had a teratoma. And he basically said, this is inoperable. There's nothing we can do for you. I'll send you down to Houston to go down to MD Anderson. They might have a trial you can enroll in, but basically, this just is everywhere. There's nothing you can do. And at that point, I was like, oh my God, you just told me I'm going to die.
Oh my God.
He didn't say it because they couch things, but that was on a day in Dallas that we had an ice storm, and we could barely make it to this appointment. He took this cardiothoracic surgeon took a lot of time to explain things. And we drove away from that appointment into the ice with my wife. And I was like, what comes now? I get a phone call literally 5 minutes after leaving that appointment. We're driving away, and it's my oncologist. She's screaming into the phone, you're CD20 positive, you're CD20 positive. I'm like, okay, I know I'm supposed to know what that means, but I have no idea what that means. And she said, it means you have lymphoma. You don't need to see a surgeon. We're going to give you chemo and you're going to be just fine. And so in the course of 15 minutes, I went through the emotions of, oh my God, I'm about to die. I need to wrap my life up, and I need to put all my affairs in order and figure out what's going on, to, oh, now I just need to find out what my treatment course is going to be, and things are going to be okay. And that makes you come to grips with where you're at in life and stuff.
Wow.
And so I had to make a lot of decisions about what to do with my practice. My oncologist told me I could keep practicing, but I was like, it's COVID, it's flu, it's RSV. You're going to be killing my immune system with chemo. The chemo I had was one where you had to be on it for a continuous week, and you carried this little bag, and it's just going to be a little waste packet. And I was like, I get it when I first started chemo. And I was like, this isn't a waste packet. This is like the size of the Scooby-Doo lunchbox I had when I was a kid, and the thing's buzzing all the time. And I'm like, the kids are going to play with it. I'm going to be exposed to it. And I realized I was not going to be able to work.
Let me interrupt you. When I saw a picture of
Yeah.
you with that pack, I thought it was an oxygen generator. Like COPDers, they get to a place where they got to carry that pack, and it's generating oxygen for them. It's that big.
Yeah, it was huge.
But at the same, this is my thought when I read and I saw that picture. What an incredibly lucky man you are.
Oh, yeah.
What an incredibly lucky man that you had a cancer that responds really well to chemo.
Yes.
And that you're here with us to be our colleague, our friend, and share that story.
Yeah. So I look back at it, and you realize like just how fortunate I was. I went through 6 months of hell. That's the most not a pleasant thing. But even then, my chemo, like I tolerated it okay. I was able to eat most of the time. There's a lot of funny stories about various disasters that happened that we can talk about another time. But overall, it was 6 months, and I'm going to be better. And I knew then that I had to think about something that Polly Bancheri is always in our heads about. It's like, you have to always be thinking about succession management. You have to be thinking about what comes next. I didn't want to have to think about who was going to cover call. I didn't want to have to think about who's going to see my patients, and made again, I told you before, I'm generally a very private person, but I made the decision that I needed the support of everyone in my community, which includes my practice. And so I was very forward about sharing my story through a blog I kept during that whole time. And that was a source of great strength and inspiration because it led to other people sharing their stories and just being inspired by being open with all the struggles that one has to deal with. And then I was like, I could not tell my patient, I could hide it. But even after I'm done and I'm able to come back to work, I'm still not going to have any hair and I'm still going to be tired. I'm still going to be exhausted easily and they're going to know. So we decided to very openly share it with my patients too. And this was at a time when people were just angry. People were done with COVID. People were done with masks. People were not being kind to their physicians because they were done with restrictions and whatnot. And when folks found out that I was sick, it was like the kindness switch just got switched on for them. And they were like, oh my God, everyone rallied around and it came on the journey together. And it's hard, but it got me thinking about what did I miss? What could I have done differently? Learned a lot of lessons the hard way.
Wow. I'm just glad you came through this and you're here with us.
And you're in solo practice, right?
I was in a small 3-person practice at the time, so it wasn't totally solo, but I was the owner. I had one person with me who I had rescued. He was one of the people that got fired in one of the great physician purges when physicians were replaced by nurse practitioners. And he came to me and said, hey, you're the practice management guru for the state. I need you to help me start a new practice, and it has to happen in the next 3 weeks. And I laughed in his face. I was like, you have got to be kidding me. You cannot start a practice in 3 weeks. So I took him in, and he has a very niche community that he takes care of, that he wanted to take care of. So I took him in, and he ended up spending 3 years, and I gave him a haven and a refuge while he figured out how to put his practice together. And then it was payback for me because then I got sick and he was ready to go off, and I'll stay for 6 more months. And I'm forever thankful for him for doing that. And now he's off and doing his thing. And then I had another person join me during that time who had recently relocated to Dallas, that was able to at least keep the continuity going for my practice so that my patients were taken care of.
So that's good. So somebody stepped up. We had 2 disasters. Herb, you don't even know about this. Way back, one of the senior partners, he was in a really bad car accident, almost passed away, lost his spleen. But the rest of the partners stepped up, and one of the senior partners developed Hodgkin's lymphoma. So he was out with chemo and all that kind of stuff. The rest of us, everybody stepped up. So those were big hits. But if there's other bodies around, the physicians really should step up.
Yeah. So from the practice management perspective, yes, succession management is incredibly important, right? But also, I think one thing that young physicians need to listen or hear is you need to have disability insurance.
Oh yeah. And not just disability insurance, but, and this was drilled into me when I was in medical school. They're like, we're going to make you buy this like platinum level own occupation disability policy. You're going to hate us for it because it's going to feel really expensive, but someday if you need it, you're going to be thanking us. And so I was super thankful to have that. I thought I had short-term disability too. It turned out that I didn't, which is why it's also important to have an emergency fund, because even if you've got the long-term disability, it takes a while for it to kick in. So you need something to float yourself while it's kicking in. And then there's also all these other kinds of insurance that I was getting ads for from the Texas Medical Association all the time, and just push them aside. And I wish that I hadn't ignored them. So if you're running your own practice, there's various kinds of business overhead insurance that's separate from your like umbrella policy. If you have an umbrella policy and that's separate from your business liability policy, that would have made things easier for me. There's also some critical illness insurances that you can get that, again, would have made things easier and wouldn't have made things such a financial struggle if I had them.
And there's also key man insurance, right? So when you're the sole owner and the manager of a practice like this, you can buy key man insurances for, what Donna Rumsfeld. That's why I put that quote, known unknowns, because I thought that was such an important lesson from a leader where he said there are known unknowns, there unknown unknowns, and those are the most difficult ones. And it's hard to prepare for the unknown unknowns. This was a known unknown. It's likely we will all get sick. We just don't know when we're going to get sick. And so it's incredibly important in your early years of practice to be protected about that downsize. And as you grow older, your expenses are less and your responsibilities are less. So both extremes, if you're a young person in your 20s, you don't have a job, you don't have a family, you don't have a mortgage, you don't really need disability insurance, you don't need life insurance. It's so terrible if you die, but there's nothing to take care of. When you're in your mid-career, when you're starting to actually be successful, there's a lot of expenses, salaries covering. And that's incredibly important to be well protected with insurance until you get to the end of the career, and then your expenses whittle again because hopefully your mortgage is paid for, your kids out of college, you're just waiting for retirement to come. Incredibly important for people that own their own practices to have very good insurance.
It was very interesting. Unfortunately, I didn't need to use it. Somebody told me, I think my father told me, you have to get disability insurance on occupation. I can tell you of 3 cases of friends of mine, my age. One that ended up having rheumatoid arthritis, has not been practicing for 20 years. She can't even hold a pen. Fortunately, she listened to me, and I don't remember telling her this. I bought on occupation disability insurance because your father told you and you told me. I have another friend, a nephrologist, ended up with some severe back spine thing, always in pain, so he no longer practices. He gets his disability. He's very good with the stock market, so he's playing the stock market, and he's still getting almost his full salary. When I met a couple of students, one that my son deals with disability insurance for Mass Mutual, and he works with the medical school. He tries to get the students. They're 20 years old, so they don't want to deal with it. But there's been a number of students that have a problem. I have a student that he can't even get it. He has non-Hodgkin's lymphoma at a young age, and he's never going to get it. We had a doctor that we tried to get, had some kind of rheumatological thing. You can't get it.
Right.
But you think,
and you're
young, you're not going to be sick, but you're going to be old one day, and you might have a problem.
Well, the other thing you have to think about too is when you get it, you're making a certain amount of money, and that's what you're covered for. And many of the good policies come with future insurability options, so that you can increase it as your income increases, so that if you need it, it actually is replacing the income that you have at the time, not the income you had when you got it.
Yeah. So that's good. Working with the students, you can get it from the school, through the school, they get a discount, and then they get the residency salary. So then it can future incomes, but it's hard. It's a hard message to get to the students.
Well, a medical student doesn't need disability insurance.
But that's when you start paying for it.
That's when you start paying for it, though.
They don't have
residency, I'm saying.
Okay, residency is different. But
right before residency.
Okay. Because as a medical student or law student, you cannot get disability insurance.
Yeah, right before residency.
You don't have income.
After match.
You don't have income until you have, and they will not insure you above 50% of your income.
Yeah.
Because that's how they prevent abuse.
Yeah.
Keep the premiums down.
Yeah, but the school works with companies, and the moment the kids can match to a program, so now they got an income coming, then they're eligible to get it. But
and they
don't.
Yeah, that makes sense at that point to get your disability insurance.
Yeah.
But it's life takes turns you don't know.
Yeah.
And you can't anticipate, and you have to be prepared. I go to bed every night thinking I'm not going to wake up in the next morning. That way, when I wake up, I'm so happy. I'm like, I'm still here. Isn't that crazy? I thought last night was it, but no, I'm still here. But that really is life. You have to plan for leaving today and save and hope that you won't for another 20 years.
Yeah.
You always have to walk that tightrope.
Yeah.
I have one more question before we let you go, because you've been very kind with your time today. But how has faith, meditation, and kindness changed the way that you see life after surviving cancer?
It's a profound change, although I think a lot of the elements were present beforehand. It's just thinking about it in a much more deliberate way, I realized, I don't know why I got cancer. Like, I have no idea. And people would ask me that. You don't smoke, you don't drink. I'm like, I know, but sometimes things just happen. But I'm sure that stress and whatever may have played some part in it, because that's who we are. We take care of others and we take on a lot. And I realized I was just not taking care of myself. Running was one of the few ways I was taking care of myself, but I needed something to really recenter myself. And I'm Jewish. I take a lot of solace in Jewish learning and Jewish belief, but was never necessarily so into the act of prayer itself. And I think prayer and meditation actually have a lot of overlap with each other and have become important. And when I started, I'd always wanted to learn meditation. I had other friends who'd been through cancer who said that meditation was usually important to them, and they encouraged me to go down that route. And it's really just a chance to step back for a moment and recenter yourself, and to make sure that you are looking at the world through your rational, intelligent mind and not through your, I think some people call it the lizard mind, that fight or flight response that so many of us get trapped in at times and that can dominate how we look at things. And I found the practice of meditation just really centering. And I've not been great about doing it every day, that as I was when I was going through treatment, where it also helps tremendously with dealing with pain control and whatnot. But I still set aside some time for it every day if I can. But I've even incorporated just little micro meditations. Like I basically, when I'm seeing patients, I take a pause for 10 seconds, 15 seconds before I go into each patient room to shut out the noise of what's been going on, to temporarily put aside the 5,000 things that I have to make sure I remember to do, and just to focus on being present for that visit, that patient, that one-on-one experience, so that I'm there for them. And that's just a tiny little practice that has made a huge difference for me. And then I came away from all of this and from learning and from just experiencing with a couple different lessons that were really important. And one is, as we talked about, to be kind. The world is full of noise and yelling and people getting into their silos and just not, talking at each other instead of speaking with each other. And if each of us could just focus on being more kind to others, we could lower the temperature of the world a lot. And when we're seeing patients, we're seeing people who, even if it's seemingly a minor issue, to them, it's not a minor issue. And that act of being kindness with our patients and just being kindness with others in general is so important. And then we also have to be kind to ourselves. We are all our own worst critics, and we beat ourselves up over stuff all the time. And it doesn't really do a whole lot of good. And so one of the lessons from meditation that one takes is that when your mind wanders, or when you drift, or when whatever, you stop and you begin again. And so in life, we have the opportunity to stop and begin again a lot, and we're going to make mistakes. But what do we tell all our trainees? The most important thing to do with mistakes is just to learn from them, not to beat ourselves up, but to learn from them, and so that we can do better next time. Another one of the lessons that came out of all this was that we should be doing something we love every day. And as pediatricians, we are given the gift to do something we love every single day. So that's a fairly easy one. And one of the quotes that came out of someone I learned from, I don't even remember who it was at this point, but it's something that kind of captures what our kids go through is that we should walk through the world with a sense of radical amazement. That there's troubles and there's ills and there's violence and there's issues. But when you really look around and you figure out how everything works together, you walk through the world to some extent the way a 2-year-old who's just learned how to wander their way around, walking and interacting with everything. It just changes your perspective on what's out there. And the last thing is that we work hard as pediatricians. And I think the best pediatricians do put the needs of their patients ahead of their own to some extent. But we have to take care of ourselves, and we have to remember that our families always come first. If we don't take care of our families, we can't take care of others and their families. And we got to figure out how to make that all fit together. And one of the craziest stories, tell this briefly. I was about halfway through treatment. It was a really hot day in Dallas, and we used to take our dog to a dog park. It's still COVID, people masking indoors still. But the dog park was like a refuge where we could be outside, we could be around each other. Went once on this really hot night. I'd do this little walk around like a 3/4 mile walking trail while my wife took the dog to the dog park. And that was my way of trying to build my stamina back up. That night, there was a pediatric pulmonologist there who I hadn't seen in a while. And he heard I was there, said he wanted to say hello. So I go into the park. The normal place for me to sit is there's too many people around. I don't feel comfortable. So I'm standing, having this conversation with him. He's just talking at me and talking at me and talking at me and talking at me and talking at me. And meanwhile, I'm starting to feel a little lightheaded. I'm starting to get really sweaty. My head's starting to drip. And I realize that it's such a hot night and I'm chemo in me and whatever. And I'm probably going through a little bit of heat exhaustion. And so I said to him, I'm not feeling really well. I'm going to go sit down. And I find this place over on the side of the park to sit down. And I sit down and I'm just not feeling great. And he's just talking at me and talking at me and talking at me. And finally, I literally lay myself down on the ground. And he finally looks at me. He says, "Are you okay?" And I'm like, "Just don't feel well." And he's, "Do you need me to go get your wife?" I'm like, "You're a pediatric pulmonologist. You should know what to do right now, not to tell me to go, not say, go get my wife." So I'm like, "Yes, go get my wife." So he goes off to get my wife and I'm lying on the ground and nobody's stopping to help. Nobody is stopping to help me. And they must think that I'm like some drug addict going through withdrawal, lying on the ground because I'm sweating and whatever. And all of a sudden I end up with a whole bunch of dogs that come over to me. And one of them is one of our friend's dogs and starts licking my face. And you can tell the dogs know that something is wrong. And they're licking my face, trying to get me to wake up and stuff. And then one of them lifts its leg up and says, "It's going to go pee on me." And finally, their owner comes over. It's like, "Pickles, get away from him." And my wife comes over, but ultimately it's my wife and friends and community that have to help you up and get you up off the ground. And there's so many little ways that we can do that for each other all the time. And so many little ways that we can do that for our patients and their families all the time. And remembering to be kind to others and to try to sit in other shoes and to try to hear the perspectives of where others are coming from, whether you agree with them or not, can really make a huge difference. And I'm thankful to be part of a community, a family, and an amazing community of pediatricians in Texas who support each other that make that happen all the time.
Wow.
Wow.
Thank you for sharing that story.
I hope you learned, Herbs. Chill out and relax. Take it easy. Smile.
As I told Sue Cressley,
Smile all the
I
time.
am going to still be screaming, "Pay the pediatricians more" in my coffin.
Okay, they should.
Oh, and just because I'm kind doesn't mean I don't scream, "Pay the pediatricians more." You can have both. But
Thank you for this wonderful gift of your time today.
Yes, thank you, Seth.
thanks for having me on.
And for everything that you've done for our community, your community, and the children in your practice.
Yeah.
I wish you the best of luck, and that from here on is full of health and continued joy and love from your family and community.
Yeah, thank you, Seth.
And to you as well.
Thank you.
You have to do it, Herb.
Thank you for listening. This has been a production of the Pediatric Lounge. On the show notes, you will find links to our co-host and other important notes, as well as a timetable of the topics discussed today. Don't forget to follow us on social media and subscribe to wherever you listen to your podcast. Leave us a great review, as it helps us greatly. In the meantime, we will see you next week. The Pediatric Lounge. The conversations are not intended as medical advice, and the opinions expressed are solely those of the host and the guest.